So you can see my disclosures. And I'd like to remind all of you that when we speak about bariatric or metabolic surgery, we are talking about a set of surgical procedures that are used to treat a host of different, distinct, although interconnected diseases. Type 2 diabetes, severe obesity. Many of our patients have coronary heart disease and heart failure, chronic kidney disease, etc. So while I do that, and I point to the fact that we have so many serious conditions that are treated surgically, and so many conditions that could also benefit from surgery, and conversely, a delay in surgery could actually cause harm because of the progression of this disease. Now, of course, we have to also recognize that each and every of those conditions have been seen as increasing risk of COVID-19 severity or mortality, as you just heard. So as a result, there is a conundrum here where, as we know that these conditions that are typically very prevalent in our surgical patient population these conditions increase severity and risk of mortality from COVID-19. So the question is, should we treat them now even more than ever and make sure that we mitigate the risk of future COVID-19, severe COVID-19, as we will go through other outbreaks throughout this pandemic? Or should we shield patients now and then treat them later when the pandemic is more controlled, where we find a vaccine so that we don't expose them to the risk of getting COVID, severe COVID, as they recover from surgery, which could potentially lead to really concerning and serious complications. Now, this question is being used by some to say maybe we should hold on resuming bariatric surgery. Let's start all other kind of elective operations, but maybe bariatric surgery. We're talking about patients that are too much at risk of postoperative complications. Let's not operate for now. But I would point to your attention that if you consider age, diabetes, hypertension, obesity, chronic kidney disease, cardiorespiratory disease, etc., it's hard to imagine that any patient who needs a surgical operation of any sort would not have one or another of those risk factors for severe COVID-19 postoperatively. So if we had to go by that metrics, we probably should shut down any elective surgery for the time being and until we find a vaccine. Now, that's obviously not a possibility because these diseases that surgical operations treat, including bariatric and actually particularly bariatric and metabolic surgery, have a very a great potential to progress and cause further harm. So if we were not to treat these patients now, we're going to find the complications of these diseases and a big, huge number of them to deal with in few months and in the years that come. But at the same time, we maintain these patients at risk for getting severe COVID if it happens, if they happen to be infected. So the question is not treating them. The question is how we treat them safely. And there is such a thing like operating safely. Yeah, we have heard this already from many colleagues around the world where they have restarted already elective surgery and they have used a number of measures that do mitigate risk of in-hospital infection and immediate postoperative COVID infection. So preoperative self-isolation of the patients for 2 weeks, testing patients for COVID-19 prior to surgery, even twice if necessary, so that we are sure we are not operating on patients who have COVID at the time we do the operation. Because don't forget that if a patient doesn't have an infection today, it will take time. There's an incubation period. Even in the worst case scenario that contagion happens during the hospital stay, the patients will be home and already likely fully recovered, especially if these patients are treated with minimal invasive surgery and laparoscopy, by the time any significant complication of that infection arises. We, of course, have to test surgeons and staff because that will diminish the exposure of patients and the potential in hospital contagion. We can try and, as the pandemic allows now, to have less people in hospitals, to make sure that there are either hospitals that are COVID-free, although nobody will be COVID-free, but less COVID, or wards that are safer. It's very important, in my opinion, that we use minimal invasive surgery. There are discussions about the fact that there's a risk for staff and surgeons to potentially contract the infection because this laparoscopic procedures aerosolize the virus. But there's no question that by doing an operation that is minimally invasive, you will give patients an advantage because they will go out of the hospital sooner and they will have less respiratory postoperative distress that could potentially complicate, of course, a potential infection. We have to discharge patients as early as possible. Again, this is ensured through many things, including the use of less invasive surgeries. And in bariatric surgery, we substantially 100% of the time use laparoscopic surgery, minimal invasive surgery. We can ask patients to self-quarantine for another couple of weeks after surgery so they can mitigate even more the infection risk after surgery. And of course, we can actively monitor and have strict follow-up. So there are ways to mitigate the risk of postoperative infection. And shouldn't that risk be a reason, in my opinion, to withhold treatment that is desperately needed from these patients? But even if we want to treat these patients, the problem is for some time, we won't have the ability to operate everybody that needs an operation. During the peak of the pandemic, it was absolutely impossible because most hospitals in the UK, but elsewhere, have been completely shut down to elective surgery. Only urgent and some cancer surgery have been performed in the past few months. But at some point after the peak, there will be periods in which the capacity will fluctuate and will allow some elective care to be done, surgical care, but not likely at usual volumes. And therefore, how do we go about ensuring that we have enough patients that need surgery now receiving the treatment, especially as we compete for limited space with many other elective surgery operations. And there will be limited space, there will be competition. So patients will have to not fight, but will have to, unfortunately, have less slots for them available for them, and each surgical specialist, each surgeon is going to fight and elbow their colleagues to find a place to serve their own patients. My problem, and I think many of my colleagues recognize, is that this is a perfect storm for bariatric surgery, because unlike other type of surgical procedures and disciplines that are normally accepted and they have public understanding of why they are needed and there is support, bariatric surgery, as you all know, has a problem. It comes with specific barriers that include a very widespread weight bias, stigma. It's very often reported as perceived and reported to be a last resort, and also sometimes too radical to do what you could do by just deciding to exercise and eat less. Therefore, it's a procedure that is more than others. Bariatric surgery is more than other disciplines considered perhaps optional. Something that you might not need today, you might need in the future. Something that the benefits of you will see perhaps in 20 years, not necessarily now. So it's probably not something that is so urgent to perform. We have also another problem in bariatric surgery. The problem is we use eligibility criteria for bariatric surgery. So in other words, we have a threshold at which we say this patient has an indication for surgery. But of all the patients who have an indication for surgery, is there a mechanism that allows us to say who should have surgery sooner rather than later? And the answer is no, we don't have that mechanism. In bariatric surgery, we have no such a thing as a system for prioritization. We have it in other disciplines. We don't have it in bariatric surgery historically. In fact, in other type of surgery, of elective surgeries, there is normally a system that recognizes even among elective procedures. Elective means procedures that can be scheduled, so they're not emergency surgery. There will be a gradient of urgency based on the patient's conditions and the disease and the ability of the disease to cause dysfunction, symptoms of potential mortality and morbidity if not treated within a month, 3 months or beyond 3 months, where one can imagine that even operating less after 3 months or more, even within a year, there is not going to be significant risk of harm for the patient. So this kind of classification exists for other surgical disciplines. It does not exist yet it did not exist yet, I should say, for bariatric and metabolic surgery. In fact, for instance, I would like to point to you this paradox. I call it the waiting list paradox. If you work in an NHS hospital, as I do, you know that there are waiting lists for surgery. Now, we don't have such a thing like a waiting list for colectomy, where you put all patients with all sort of disease, cancer, diverticular disease, inflammatory bowel disease, polyposis, benign and malignant disease on the same waiting list with the same seniority and with the same priority, if you wish. In bariatric surgery, we basically put a lot of different conditions in the patients with different conditions and disease, with different stages of disease, with different risk from harm from delaying the interventions on the same waiting list with the same seniority, with a sort of first come, first served mechanism by which we advance them towards surgery. And I think this is entirely medically inappropriate, but is also potentially ethically problematic. So why do we need a triaging system in elective operations when we resume the elective operation? And I'm really hoping that this will happen soon. Because surgical delays will harm some patients more than others. And that's not every patient has the same risk of harm if the surgery is delayed. We don't have, as I said, a prioritization system. We only have weight-based criteria that do not identify, this criteria do not identify patients who are more or less at lesser risk of harm from delayed surgery. But we also deal with another issue here, and my colleagues endocrinologists here might agree, I hope, with me, that even in diabetes or obesity, we don't use prognostic factors very often, or as often as we should, as we do in other diseases, for instance, in cancer, to determine what is the next level of therapy, what is the priority to therapy as we change therapy, if we adjust therapy, et cetera, et cetera. Prognostic is a type of prognostic mechanism that we use in other surgical disciplines. It doesn't belong to bariatric surgery, but perhaps doesn't belong also to diabetes and obesity care. So we're really in a sort of perfect storm here. And that's why we thought that we had to organize an immediate consensus conference on this subject to understand how we prioritize access to bariatric metabolic surgery so that we use a medically meaningful and ethically meaningful mechanism to do so. This is a Diabetes Surgery Summit at DSS. For those of you who don't know, it's a historical consensus conference series that we have organized in the past for other matters related to diabetes surgery for diabetes. And so what we did with this, many of the experts involved in this consensus conference are actually here participating in this webinar. We used substantially the same thing. We didn't reinvent the wheel. We used the same thing, the same mechanism that is used in other type of surgery, so that we grade the degree of urgency by which a surgery should be performed based on the severity, the stage of the disease, and the likelihood that that disease would progress or harm a patient if left untreated. And so we divided the indications to bariatric surgery conceptually in whether patients have diabetes, and primarily the indication at that point is diabetes. We call it diabetes surgery, obesity, or other conditions that we often operate for, which are conditions where bariatric or metabolic surgery is necessary to operate, to facilitate another type of treatment, whether it's surgical treatment like orthopedic surgery, transplant, or even other forms of treatment like for cancer, etc. The patients cannot have that treatment at that time because of having their weight is too high for safe surgery, or their metabolic control is not good enough to engage into more aggressive forms of treatments. And so surgery is there used, bariatric surgery is used as an adjuvant type of therapy. And so we differentiate this condition, these indications, but also we identify patients' conditions based on prognostic factors of harm, of disease progressions, to identify those who need expedited access and those who need standard access. And that's the exercise we made through this consensus conference. Now, just very briefly, are there predicting factors of mortality, morbidity, or factors that are associated with decreased quality of life in people with type 2 diabetes? As you know, not everybody who has type 2 diabetes has the same problem. And yes, there are such things like prognostic factors. There is history of cardiovascular disease that it's absolutely associated with increased risk of mortality and morbidity from diabetes. The use of insulin is also associated with overall and cardiovascular mortality in people with diabetes. And so of course, other metabolic conditions. And of course, we also have to consider, on the other hand, what is the likelihood for that level of stage of diabetes that surgery would actually impact that prognostic factor in a meaningful way if we did it today. Particularly important is whether the issue of remission of diabetes, which is very likely to occur with surgery, but is less likely to occur as time goes. And so the earlier the intervention, also the more likely the operation will to be successful. So these factors have also to be computed into how we assess the need and the urgency of surgery. And so based on those factors, we identified a number of scenarios where we think that patients with type 2 diabetes that do not achieve adequate control despite the sufficiently organized and well-organized medical therapy with oral meds, patients on insulin, as I said before, because insulin signals a more aggressive disease, patients who already had a history of cardiovascular disease, they are more likely to potentially have a problem if we operate into next year as opposed to relatively sooner. And so people with NASH, because NASH does have a major impact on cardiovascular disease progression, or people with chronic kidney disease that could progress into more severe renal disease or renal failure, etc. And all the other conditions will be still conditions of necessity for surgery, but conditions where a delay in surgery might be less likely to cause harm. The same exercise can be done for obesity. Obesity also is not the same thing for everybody. Situations like respiratory failure, heart failure, the multiple comorbidities associated with obesity and renal disease can also signal a condition of obesity that could be similar to having an advanced stage of disease, a more severity of disease, and a disease that is more likely to progress sooner. So based on those situations, we did consider that patients with high level of BMI, who obviously have also an impact on quality of life, should have surgery sooner. Patients with cardiometabolic conditions, multiple conditions like NASH and others, patients with severe respiratory problems that would potentially be particularly significant if these patients got COVID, including if they got COVID, etc., and renal disease. And so we have now introduced in this paper that we published in the Lancet Diabetes a couple of months ago, a mechanism that we believe is useful because it does identify and prioritize patients that have the greatest need, as opposed to a seniority on a waiting list. It is specifically designed to reduce risk of harm from both baseline disease and possible severity of COVID if it happens in the next few months, etc. Because the surgery works so quickly, you can actually mitigate that risk quite rapidly by improving both obesity and diabetes and other conditions. It provides a compelling case also for prioritization as we compete with other surgical specialties where prioritization will be based on urgency. And so we have to compete with the same criteria. And also, I think it does provide this mechanism a long overdue opportunity for a long overdue overall of our methods of patient selection and prioritization in bariatric surgery. Many of the colleagues who participated in the consensus conference and co-authored these papers are part of this webinar. And I want to emphasize that these recommendations have been endorsed by multiple organizations, particularly important here in the UK, the British Obesity and Metabolic Surgery Society. The president of the society is here with us in the panel. Thank you.